This is our last day of the conference, and I hope you've enjoyed the second day and are ready for more exciting lectures. And now I'm going to introduce a very interesting session, and it concerns all of us, and it's the coming epidemic after viral hepatitis. It's concerned with Nafld and NASH management in Africa. And it's my honor and pleasure to introduce Professor Jeffrey Lazarus from Barcelona Institute of Global Health in Spain, presenting on Nafld NASH policies and practice in Sub-Saharan Africa. Professor Lazarus holds positions as Associate Research Professor at Barcelona Institute of Global Health, Hospital Clinic University of Barcelona. He leads the Health Systems Research Team and as an Associate Professor at the Faculty of Medicine, University of Barcelona, Spain. Professor Lazarus is Vice Chairman of the Board of the EASL International Liver Foundation, a member of the INSRU International Education Committee, and co-chair of the HIV Outcomes Beyond Viral Suppression Coalition. Professor Lazarus.
Good afternoon, and thank you very much for the opportunity to present here at COLDA. Hopefully next year we'll be able to meet in person. The title of my presentation is Nafld in Africa, and I'll also be presenting specifically about the work the EASL International Liver Foundation, where I sit as Vice Chair, is undertaking in this area. These are my disclosures. Now, the EASL International Liver Foundation was created by the European Association for the Study of the Liver as a global nonprofit organization committed to increasing the quality of life and reducing premature mortality for the greatest number of people by improving liver health. Our vision is that everyone deserves a healthy liver, and our values reside in solidarity, impact, integrity, and neutrality. This is our board, and you'll recognize Manel El Sayed, who is among the conveners of COLDA, as well as many experts in the field of hepatology and other areas. The four program pillars of the foundation's work are research, education, interventions, and awareness. So why did we decide to prioritize Nafld and NASH? Well, Nafld is a global issue. It affects somewhere around 1 in 5 people around the world. The prevalence varies greatly between countries. It has a serious health, economic, and social implications. And it's a complex challenge requiring us to work across disciplines and sectors to find solutions. Finally, it's a silent epidemic. Unlike HIV, which we're well aware of, and viral hepatitis, which the world is now well aware of, COVID-19, and others, Nafld has received little attention from policymakers or the public health community. Now, there's little available Nafld prevalence data for Sub-Saharan Africa. If you look here at the map, you'll see that most of Africa is in gray because no data is available from the time of this study a few years ago. But you will see that in the countries where there is data, from South Africa to others in North Africa, the prevalence is estimated as high as over 30%. And we have really no reason to believe that the prevalence in Sub-Saharan Africa would be much different than in other parts of the world. And in other parts of the world, we largely see prevalence rates from between 10 to 25%. On the right, you can see 2 studies, one from Sudan, one from Nigeria, showing prevalence rates of around 20% and around 8.5%. Those are older studies, and we know that in general, very little is known about the prevalence of Nafld, similar to viral hepatitis a few years ago and similar to HIV many years ago. So what are the risk factors? Well, we do know that obesity is a major driver of non-alcoholic fatty liver disease. And for obesity, we do have good global data and strong data from Sub-Saharan Africa as well. So here you'll see that most countries have at least an 8 to 10% prevalence, and some countries as high as over 1 in 4 or even a third of the population being reported to be obese. So what are we doing in this area? Well, the foundation is working with partners to advance the Nafld public health research agenda. It's not just prevalence that we don't know a lot about. We also don't know about what kinds of models of care are in place and what's working and what exactly we need to do in terms of clinical care pathways and addressing the public health and health systems issues that can be addressed to address the clinical issue of Nafld. We're trying to link Nafld to the Sustainable Development Goals, and we're working with partners, and you're welcome to contact me or the foundation to develop a call to action to be launched at International NASH Day, the 12th of June in 2021. So we're sounding the alarm on this silent epidemic. We've held a series of regional workshops with the Economist Intelligence Unit that I'm going to tell you a bit more about. We're working with the UK-based think tank Wilton Park on policy events, and we have publications in journals like Nature Reviews Gastrohepatology and BMJ Opinion and others on the way to mark International Day to draw attention to the issue, but also to focus on issues like models of care and linking Nafld to the SDGs. We're also working to build consensus for a roadmap addressing what we need to do to address Nafld-NASH as a public health challenge, and to create a network of global experts and thought leaders to guide this process. And finally, we're working to provide a platform for patients and patient advocates to engage in the dialogue and shape these discussions. We don't want to make the mistakes we've made earlier with other conditions by not involving civil society, patients, and other important groups from the beginning. So I mentioned the global review of Nafld and NASH related policies that we're undertaking. We originally carried out this study in Europe. Now we're undertaking a global study of which 90 countries have provided data, including 13 in Sub-Saharan Africa. You can see them below. And if any of you are from countries not on that list, do contact us, because we would very much like to expand the number of countries providing information about Nafld and NASH in their country. And these findings will provide a baseline for future efforts and can support knowledge sharing between countries and regions. It will also be used to develop a policy index for tracking national, regional, and global progress. You see here on the right from the European study of 29 countries, the first question we asked was, does your country have any written national Nafld or NASH strategy or action plan? The answer was no. And without sharing all the results for the 90 countries that we've studied now to date, the answer continues to be, unfortunately, no. So let me share with you some of the interim findings from this global policy review. If you look at the top line, you see the data from Sub-Saharan Africa. At this stage, we've compiled the information from 9 of the countries. None have a strategy, as I already mentioned, but none have guidelines on Nafld-NASH. And look at this compared to other parts of the world, including Europe and Central Asia, where more than 1/3 of the countries do, or Latin America and the Caribbean, where 5 out of 8 do. That doesn't mean that you may not use guidelines published elsewhere, but it means that your country, your professional organizations have no specific Nafld or NASH guideline. There are no registries in Sub-Saharan Africa, though 3 countries did report that they are implementing lifestyle programs in response to Nafld-NASH. And that's extremely important in the absence of any available treatment. Regarding the management of Nafld in Sub-Saharan Africa, here are the interim findings from the 9 countries reporting. We asked about professionals responsible for managing patients with Nafld, and you'll see that it's mostly gastroenterologists, also internal medicine specialists and hepatologists, no surprise there. In one country, they reported a primary care physician, and in one, a multidisciplinary team. We believe that multidisciplinary teams are essential in the management of Nafld, given that it's a metabolic syndrome. Countries in which primary care providers are responsible for the care of the following conditions that are common comorbidities, obesity, diabetes, type 2, metabolic syndrome, and harmful alcohol use. You can see here that primary care does play a role, which means that it's extremely important that primary care physicians are somehow connected to the specialists in order to refer them on to care, or in order to provide the right care if seeing a specialist is not needed. Now, I mentioned that the EASL International Liver Foundation is working with the think tank Wilton Park. Because Nafld has received so little attention within the non-communicable disease movement and other global health policies, such as the Sustainable Development Goals and universal health coverage, we set up a series of meetings to conduct high-level dialogues which aim to provide strategic direction for advancing the Nafld policy agenda. We've established an advisory board of global experts, including hepatologists, NCD specialists, public health experts, and patient advocates to guide this process. So Nafld care requires multidisciplinary approaches with increased coordination and collaboration between disciplines to ensure timely diagnosis of the condition and the appropriate management of common comorbidities. Together with Wilton Park, we had a meeting on the models of care that would be able to do this. Clear policies are needed to shape the grounds for the development and implementation of innovative care pathways for Nafld patients, specific to their position on the disease spectrum. That meeting was held last June, and we shined that spotlight on improving models of care. It was largely focused on Europe, but we are expanding that to become a global study and focus area of our work. And at that meeting, we had 30 experts who reviewed a draft call to action, which I will also share with the participants at COLDA when it's ready, where we outline 7 recommendations for improving models of care. We're also leading a systematic review to identify any published examples of comprehensive models of care, which can strengthen the global evidence base. Unfortunately, though not surprising, none of those are in Sub-Saharan Africa. That is something that will have to change in future, and I hope at future COLDA meetings we'll be able to address models of care specifically for Nafld and NASH, just as we've done for viral hepatitis. Now, those recommendations are still in draft form, but they're really focused around what services should be provided, where should services be delivered, who should deliver services, and how do we ensure coordination and integration. Now, we're planning a second Wilton Park meeting, hopefully face-to-face this coming December, again, bringing together thought leaders and other experts from around the world in order to address the creation of this global coalition, which will steward efforts to advance the Nafld public health agenda. We're also running a series of 14 workshops together with the Economist Intelligence Unit focused on Asia, Latin America, and the Middle East this year, but hopefully Sub-Saharan Africa sometime next year. And through these workshops, we aim to identify and understand the opportunities and challenges for addressing Nafld and NASH at the national, regional, and global level, from improving care to integrating Nafld into public health policies. The series specifically addressed screening, diagnosis, and referral pathways, integrated models of care for patients with Nafld and NASH, and incorporating Nafld into the NCD movement and broader public health efforts. And we'll be providing a series of summaries with the key learnings from the series. Here are some of our recent publications that I mentioned when I was presenting the work of the foundation. So on World or International NASH Day 2020, we launched a comment called Nafld sounding the alarm on a silent epidemic, but at the same time, we focused on envisaging a new, better normal for all non-communicable diseases, including Nafld, which is often left out of the NCD agenda. So let me thank my colleagues at the International Liver Foundation for the incredible work they've been putting into building the coalition and really building the foundation's platform for NAFLD, NASH, and coordinating with so many different partners, as well as Nancy Lee at Wilton Park, the experts at the Economist Intelligence Unit, and all of the participants at the EIU workshops, at the Wilton Park meetings, the various patient and civil society groups that have been providing us with expert input on really what we need to do as a foundation to advance the NAFLD and NASH agenda. Thank you very much.
Thank you very much, Jeff, for this great presentation. And we hope that many countries in Africa will join the coalition of NASH. And now we go to the next speaker. I would like to introduce Professor Joel Dave from Groote Schuur Hospital at University of Cape Town, South Africa, presenting on diabetes, obesity, and COVID-19. Professor Dave is head of the Division of Endocrinology at the Groote Schuur Hospital and the University of Cape Town. His main research interest centers on infectious disease and the endocrine system. He was part of the team that set up the COVID clinical service at the Groote Schuur Hospital in Western Cape Town, the epicenter of the pandemic in Africa. He's been involved on the front line of this pandemic for the past 6 months. Professor Dave.
Good afternoon. I'd like to thank the organizers for inviting me to give this talk today on the association between diabetes, obesity, and COVID-19. It's not unprecedented that diabetes has some association with an infectious disease, and there is an increased risk of infections in people living with diabetes. And if we look at another two current day pandemics, namely TB and HIV infection, there's also a strong association with diabetes. I've no disclosures that are pertinent to this talk today. And just a quick outline of the talk. I'm first going to review the prevalence of diabetes and obesity globally and in Africa. We'll then explore whether there are plausible pathophysiologic mechanisms explaining why patients with diabetes or obesity would be at greater risk of infection or complications from SARS-CoV-2 infection. We'll then look at some global data on the association between diabetes, obesity, and COVID-19. And then we'll have a look at some local Western Cape data on the association of diabetes and COVID-19. This slide just goes to remind all healthcare workers that there are now over 450 million people living with diabetes globally. And if we focus down on Africa in the bottom left-hand corner, you can see that over the next 10 to 20 years, Africa is going to experience the greatest increase in prevalence of diabetes, increasing by about 143%. If we then take a snapshot of the Africa region, you can see that South Africa is the leader with the greatest number of people living with diabetes, but there are at least already 5 countries in Africa that have over 1 million people living with diabetes. This is also on the backdrop of an increasing prevalence of overweight and obesity in Africa over the last 2 decades. And this is greater in women than in men. And so there's no doubt that it was destined that these 3 pandemics were going to meet. And so the question now is, are there plausible pathophysiologic mechanisms explaining why patients with diabetes or obesity would be at greater risk of infection or complications from SARS-CoV-2 infection? This slide is now very well known to everyone, and it describes the entry point of SARS-CoV-2 into cells using the ACE2 receptor. Once the ACE2 receptor is downregulated, you can see that the flux of the whole pathway is driven down the angiotensin II pathway, ultimately leading to hypertension, cardiac fibrosis, thrombosis, and ARDS, all things we know that are part of complicated COVID-19 infection. And in people living with diabetes, ACE2 receptors are increased, especially when they are hyperglycemic. there is a background of endothelial dysfunction in people living with diabetes and obesity. And it's now become quite well described that in the setting of COVID-19, there's an endotheliitis. And all three of these things, these entities, putting pressure on the endothelium and increasing release of pro-inflammatory cytokines, all aid the formation of the cytokine storm that ultimately leads to multi-organ failure. And if you have a look at the description of the organs involved in multi-organ failure, you can see that these are quite typical of quite severe COVID-19. So if we have a look at a summary then of why diabetes may put you at risk, the entry of the SARS-CoV-2 into the respiratory tract is like in anyone else. You get infection of the respiratory epithelium and ultimately the development of a pneumonia. There is increased ACE2 expression in people living with diabetes, and especially on the cardiac myocytes and in the kidney. And then it's also very well described in people living with diabetes that there is a dysregulated immune system, all putting one at risk of developing a cytokine storm and multi-organ failure. And not to forget that this is generally in patients with type 2 diabetes who are usually of an increased age, they're usually overweight or obese, and they have some degree of pre-existing vascular disease or pre-existing kidney disease, all of these which have been associated with more severe COVID-19. A very interesting question that hasn't been fully answered yet is whether actually SARS-CoV-2 infection can cause diabetes. We know that in the SARS pandemic, there were cases of new diabetes, and it was shown that the spike protein was toxic to beta cells. We know now from the literature that there's frequent reports of new onset diabetic ketoacidosis, and there's also frequent reports of people requiring large doses of insulin in order to maintain euglycemia. It's very important to remember that obesity is a state of low-grade chronic inflammation with areas of hypoxia amongst the adipocytes, which drive a pro-inflammatory environment, especially with TNF-alpha, interferon gamma, and interleukin-6, and especially the interleukin-6, which has been associated with a cytokine storm. And so it's this milieu of chronic low-grade inflammation that may place overweight and obese people at risk of developing more severe COVID-19 when infected with SARS-CoV-2. We also know that obesity is associated with some degree of respiratory dysfunction. There's often associated comorbidities, and they also have metabolic risk factors, which together would likely all culminate in more severe course of COVID-19. An interesting theory that has been put through is that SARS-CoV-2 gains entry via the respiratory system. There's extra pulmonary organ spread, and we know that there's a predominance of ACE2 receptors on adipocytes, and the SARS-CoV-2 virus gains access to these adipocytes, and then these adipocytes act as a reservoir for viral shedding, thus prolonging and aggravating the course of COVID-19. And this is just a summary of everything that I've said in the setting of obesity, showing how chronic inflammation, a dysregulated immune response, dysfunctional metabolism, an imbalance in epithelium, and dysfunctional immune cells all could potentially put someone who is overweight or obese at risk of developing more severe COVID-19. And so now that we've had a look at the possibility that there are actually pathophysiologic mechanisms explaining why people living with diabetes or obesity could develop more severe COVID-19, the next question then is, actually do they? And to initially outline this, I'm going to use global data. And the first question we need to ask ourselves is, do people living with diabetes have a greater risk of being infected with SARS-CoV-2? Now, this is a very difficult question to answer because the information that we need is the number of people with diabetes that have been diagnosed with COVID-19. And then we need to know everyone that has had COVID-19. Now, we know that many people have asymptomatic infection. And to know the denominator is impossible at the moment because many people have escaped diagnosis because they've been asymptomatic. And then all the articles in the published literature are generally on the more severe COVID-19 with those that have been hospitalized. But the data that is available from other countries basically shows that there is no increased prevalence of diabetes in all patients diagnosed with COVID-19, suggesting then that people living with diabetes or obesity are not at greater risk of getting infected with SARS-CoV-2. However, the next question is, once they are diagnosed with COVID-19, do people living with diabetes or obesity have more severe disease when they have been diagnosed? And I'm going to use the initial studies from 3 or 4 of the countries in the Northern Hemisphere that have been hardest hit by this pandemic to illustrate the point. There are now multiple studies in the literature essentially showing this at the moment. So if we have a look at the first study from the United States on 5,700 patients admitted to hospital, at least 1/3 had pre-existing diabetes, and people living with diabetes were more likely to require admission to the intensive care unit. In a large study from Italy on about 1,600 patients admitted to the ICU, 1 in 6, 1 in 7 of these patients had pre-existing diabetes. And in a large study from China, if you have a look at the overall case fatality rate, it was 2.3%. But if you focus then on people living with diabetes, it was 3-fold higher. In a large study from the United Kingdom, looking at 17 million adults that had accessed the national health system in the year prior to being diagnosed with COVID-19, and you can see that obesity and increasing obesity and diabetes were both associated with a greater mortality from COVID-19. There are now multiple studies and systematic reviews and meta-analyses and cohort series. I've just used 3 here to illustrate the point, but essentially all of them show that obesity increases your risk of more severe COVID-19 disease. It increases your risk of requirement for admission. It increases your risk for admission to an intensive care unit. And unfortunately, it also increases mortality from COVID-19. But also just to say, before we change the slide, that all these studies are observational studies. So although there's now a plethora of data and meta-analyses and systematic reviews, all the data is essentially mainly showing an association between diabetes, obesity, and more severe COVID-19. We can't, at this stage, imply causality. So then let's look at some data from the Western Cape that for many months was the epicenter of COVID-19 in Africa and in South Africa. This was data that as of the beginning of July 2020, and at this stage in the Western Cape, there were about 72,808 people that had been diagnosed with COVID-19. And of those, about 7,000 had pre-existing diabetes. And so this put the prevalence of diabetics in this population at 9.6%. And if we have a look at the background prevalence of diabetes in our population, which is widely quoted to be somewhere between 10 to 12%, you can see that there actually isn't a greater prevalence of people living with diabetes in the COVID-19 population, suggesting then that people living with diabetes are not at greater risk of becoming infected with SARS-CoV-2. However, if we have a look at these diabetics, almost 50% of them required admission to a hospital, showing that they were more likely to have more severe COVID-19. And of those of which we have an outcome, which was about 2,201 patients, there was a very high mortality of almost 43%. Again, now showing that diabetes spells a more severe course of COVID-19 with greater morbidity and greater mortality. A recently published comorbidity report from the Western Cape, having a look at the association with COVID-19 death in all Western Cape public sector patients who were over 20 years of age and who had accessed the public healthcare system in the prior 3 years. So this was a population of about 3.5 million people. It was quite well shown that diabetes by itself was a risk factor for death. You can see here diabetes with a well-controlled A1C was a risk factor, and this increased dramatically if you had poorly controlled diabetes, such that people living with diabetes who had an A1C greater than 9% had a hazard ratio for death from COVID-19 of 12. One of the interesting associations from some of the data from the Western Cape was showing that 80% of all people living with diabetes who were admitted to hospital were actually diagnosed with COVID-19 on the day of their admission or after their admission, essentially showing that these patients were presenting late with their symptoms and presenting when their symptoms were severe enough for them to require admission. I think therein lies the opportunity potentially to intervene if we can get people living with diabetes to present earlier. When their symptoms are milder, one could potentially put in place some type of monitoring, some type of telemedicine to help and to monitor these patients and to ensure early access to healthcare facilities to possibly decrease the morbidity and mortality associated with their course of COVID-19. There's very preliminary data at the moment, and it's quite sparse, to show that if one is able to control diabetes when the patient is admitted to hospital, one could change the outcome. This is a study from China where they had a look at the glucose variability in patients that were admitted. And what they found was that if patients were able to keep their glucose readings between 4 and 10, the outcome was much better than if they had excursions that were greater than 10 millimoles per liter. And you can see over here that those who had poorly controlled diabetes had a greater mortality than those who had better controlled diabetes. So in summary then, there was bound to be a meeting of the pandemics of diabetes, obesity, and COVID-19. There are plausible putative mechanisms suggesting why people living with diabetes or obesity would have greater morbidity and mortality from COVID-19. Data at the moment doesn't suggest that people living with diabetes or obesity are at greater risk of being infected with SARS-CoV-2. People living with diabetes or obesity are more likely to have more severe COVID-19 with a greater morbidity and mortality. And it seems that very early data shows that if one could control glycemia in the context of an admission and in hospital, one may be able to change the outcome in these patients. Thank you very much for listening, and I'm happy to answer any questions.
Thank you very much, Professor Dave, for this great presentation. And now it's my pleasure to introduce my friend, Professor Ponsiano Osama from Makerere University College of Health Sciences in Uganda. presenting on fat and the liver in African population. Professor Osama is Professor of Medicine and academic hepatologist in Makerere University College of Health Sciences in Kampala, Uganda. And he contributed to the hepatitis guidelines of WHO.
So I would like to thank the organizers of this conference on liver diseases in Africa, which is an important conference, really. And I thank you for inviting me to give this talk on fat and the liver in African population. I just would like to say I really have nothing to disclose as far as this presentation is concerned. In the outline, I will give a brief definition of fat in the liver and the etiology, and we look at the burden of fatty liver, global and also African, and the progression of liver disease diagnosis, and then I will conclude this presentation. By definition, really, fat in the liver is basically accumulation of fat in the liver, and it can be because of alcohol or some drugs. For example, some of the medicines used for treating HIV, but it can also be non-alcoholic, which is basically obesity, type 2 diabetes mellitus, which is also can be part of metabolic syndrome. For this presentation, I am going to basically confine myself to the non-alcoholic fatty liver. So this is accumulation of fat in liver in the absence of excessive alcohol intake, and it encompasses a number of stages. We can just have simple steatosis or fat in the liver, but this can also progress to inflammation as NASH, with or without hepatic fibrosis. And this can progress to cirrhosis, and eventually some of these patients will end up with hepatocellular carcinoma. The burden of Nafld varies really from place to place and from population to population. And it is really based on the risk factor distribution. And in some of the populations, it will be due to sensitivity of the detection methods that we use. In terms of the prevalence, therefore, globally, it is thought that about 25% of the general population actually have got Nafld. And this, of course, like mentioned earlier on, it will vary, and diabetes and obesity form part of the major risk factors for this Nafld. In Africa, as you can see from this slide, about 13% of the population is thought to have Nafld. And as you will see later on, there are quite a bit of issues with the data collected in Africa, because the studies have not been really done systematically in a number of places, in a number of populations in Africa, to define the extent of Nafld in this population. In this data, which was collected together by Paruk and published last year from some of the African studies that are looking at Nafld in several populations, looking at the population and the detection methods and some of the risk association, you will see that most of the Nafld that we are talking about is found among populations which have got type 2 diabetes. As you can see from studies from Nigeria, where up to about 68%, in fact 69% of the patients with type 2 diabetes were found to have Nafld, and these cuts across in the Sudan up to 50%, and in Ethiopia 73%, and in South African studies. this has been shown to go up to 87%. So you can see that the driving factor here is actually type 2 diabetes mellitus, even in the African population. I want to draw your attention to the fact that the detection method in most of these studies, in all of them actually, was the abdominal ultrasound scan of the liver, and only in the South African study, biopsies were actually done to detect Nafld in this population. And so we will see later on that the abdominal ultrasound scan really has got a relatively low sensitivity for detection of this condition. We see that even in the developed world, that there has been a lot of studies looking at NASH and the trajectory of diabetes and obesity. And you can see that diabetes is thought, if you take the aggressive trajectory, you can see that by 2050, it is anticipated that there will be probably about 90% of the population with the Nafld. But if you are conservative, you can say about half of this population. And this also affects it goes together with the obesity trends. Obesity is also on the rise. And so all these things that we are talking about do not leave out Africa because, as you will see in this next slide, there is a rising epidemic of diabetes in Sub-Saharan Africa. Currently, it is reported about 19 million adults have actually got diabetes mellitus, and most of whom are actually type 2 diabetes mellitus. And this is expected to reach up to 47 million by 2045, especially if no control measures are actually put in place. And this is a problem because this is where we are going to end up with the NASH and Nafld. Amongst the patients with type 2 diabetes mellitus, we can see in Africa, we have currently a report of about 30.4% of the population with type 2 diabetes mellitus actually having Nafld. Now, this is not a small number, and this will lead to a number of impacts, especially looking at the type of capacity and availability of equipment for detection and also management of some of these patients that will be found to have progressive liver disease based on, from the Nafld itself. Certainly, fat in the liver is not benign, and we've mentioned this already. It starts just like a simple accumulation of fat in the liver, but this eventually progresses to attracting inflammatory cells into the liver and then causing destruction of the liver cells, eventually causing scar tissue within the liver, ending up with cirrhosis and eventually liver cancer in some of the patients. Again, you can see again that because of the nature of Nafld and its progression, that this study, which is done mainly in North America, shows that there will be an increase in the all-cause mortality in patients from those who do not have fatty liver and those who have got fatty liver, and then eventually those who have got NASH. And so there is increasing risk of dying once somebody has fatty liver and progressing to the inflammatory phase, which is really steatohepatitis. Now, comparing those non-diabetics and diabetics with NASH and Nafld, you see the progression of the disease seem to be a little bit much slower and in fewer people from the Nafld to NASH, and then eventually to cirrhosis, and then to hepatocellular carcinoma, leading to mortality and liver transplant. But those who have got diabetes, this progression is a little bit rapid, and the percentage of those persons who actually progress from Nafld to cirrhosis and hepatocellular carcinoma seem to increase in patients with diabetes compared to those who do not have diabetes. Eventually, of course, once hepatocellular carcinoma is reached, then there will be need for liver transplant, and of course, mortality will be enhanced. Also, in patients who have cirrhosis, these, in our case in Africa, you will find that the preparation is not adequate to actually take care of these kind of situations, and so mortality is expected to be increased. This study, this report, which was compiled by Ahmed and published last year, shows, in 2017, shows that in looking at several studies which has been conducted looking at diabetes and obesity and metabolic syndrome in various African and Middle East countries, you will see that the population with diabetes varies from country to country. Obesity also varies from country to country. Metabolic syndromes, the same. Now, I can see, for example, in the Ugandan study here, where metabolic syndrome was defined in 58%. This is basically because of the heterogeneity of the population that has been studied. In this particular case, the Ugandan study actually was done among diabetics and showing metabolic syndrome in up to 58% now. So we have a huge population of patients who have got diabetes, who actually, diabetes and obesity, who eventually will end up with Nafld and NASH and its complications. In terms of signs and symptoms, really, most patients with Nafld will not present with any sign. In a few cases, there may be some fatigue, malaise, dull right upper quadrant, abdominal discomfort, and really, these are not very common at all. And mild jaundice may be seen very rarely. Most diagnoses done in patients who are found to have abnormal routine liver function tests. Just to say that this is a practice which is not common among many Africans, to go and basically do routine tests. And so many times something is bringing the patient to the clinic to see the doctor, other than just walking in to see the doctor. And so most times the diagnosis is really delayed to be made. And most patients' diagnosis will be made when complications have already taken place. What about the tests? The tests are done basically for the risk factors, and this has been mentioned already. But then there are also now investigations to define and really quantify, if it is possible, the Nafld, and these will include liver biopsy. Now, this is fraught with complications, and so many patients will not accept liver biopsy to be done. Ultrasound scan is the one which is relatively widespread, but it has a relatively low sensitivity, although now probes are being developed which can actually pick fatty liver properly. And we hope that these probes can be found in many parts of Africa so that studies can be done. The MR spectrometry is still expensive, as well as the transient elastography with the controlled attenuation. These are tests which are not yet very much available. They are very, very rare, and they're quite expensive. And so because of these kind of testing issues, it becomes a little bit difficult for many population studies to be done to really define the extent of fatty liver in African population. Hopefully, if the ultrasound scan probes which can detect fat becomes really widespread, this will improve on the studies that will help to define this burden. So there are several challenges of fat and the liver in African population. First, there is increasing burden, but we have a very limited population data. And this really needs to be worked on. Control mechanisms are not readily available in most of our countries in Sub-Saharan Africa. So we need most accurate diagnostic tests, but most of them are expensive and they're not really readily available. So we need a lot of advocacy involving various stakeholders. So in conclusion, Nafld is a looming epidemic in Sub-Saharan Africa, and this is because of the increasing prevalence of obesity and type 2 diabetes mellitus, and the concerted efforts will be required by various stakeholders to define the current situation in terms of the burden of this condition and establish control mechanisms, and finally to really prepare for care and management of patients should this epidemic strike us, including setting up liver transplant facilities. Very expensive, and most Africans would not be able to afford this kind of treatment. Thank you very much, and again, thank you for inviting me to give this presentation.
Thanks very much, Professor Osama, for the great presentation. And now we move to the live panel discussion, and I would like to remind the delegates to access the panel discussion. You have to click on the Zoom link on the right side of the page under session information. Thank you.